Prone positioning a child enrolled in the Prospect trial must be done carefully to ensure that the child remains safe and comfortable throughout the reposition. Prior to repositioning the child, the bedside care team should carefully review the Prospect prone positioning checklist. The number of team members required should be determined, and all supplies required should be gathered and brought to the bedside. Prior to repositioning the child, the procedure should be thoroughly explained to them, and they should be talked through the turn throughout the procedure. Consideration should be given to the need for additional analgesia, sedation, and/or neuromuscular blockade to ensure the child's comfort and safety throughout the turn. The most recent chest X-rays should be reviewed for placement of the endotracheal tube, the tip of which should be positioned in the lower third of the thoracic trachea. The bedside team should ensure the security of the endotracheal tube, all vascular lines, and all other invasive lines such as nasogastric tubes, chest tubes, or Foley catheters. Dressings should be reinforced as necessary. If the child is receiving neuromuscular blockade, apply lubricant and consider application of a barrier dressing to both eyes. A plastic film and/or barrier wipe should be placed over anterior bony prominences, especially in children supported on high-frequency ventilation in order to prevent friction injury. ECG leads should be moved to the lateral aspects of the upper arms and hips. The oxygen saturation probe should be placed on a limb that will be going over top of the child during the turn. Any unnecessary tubes or lines are disconnected, such as NG suction, temperature probes, etc. If the child is being fed, consideration should be given to the timing of last feed and/or holding feeds until the child is settled in the prone position. Immediately prior to turning the child, the team should clearly discuss the roles with the bedside RN directing the turn and the team member at the head of the bed ensuring the safety of the endotracheal tube throughout the turn. The child should remain connected to the ventilator throughout the turn. All cushions or positioning materials and any clothing or hospital gowns are removed. A new draw sheet is placed over the child. The edges are rolled together to create a mummy effect. Using all bed linens under the child, the bedside team slides the child to the edge of the bed away from the ventilator. The child is then turned 45 degrees towards the ventilator. The team pauses and reassesses the child for comfort and physiologic stability. The child is then positioned prone on the new linens. Throughout the turn, the child's head should be kept in alignment with their body, avoiding hyperextension, keeping the arms next to the torso, with the toes of the upper leg pointing in the direction of the turn. Old linens are then removed. The child is assessed throughout and immediately following the turn for comfort and physiological stability. Any monitors or devices that were disconnected are reconnected. Linens under the patient are inspected to ensure they are free from folds or wrinkles. An absorbent pad is placed under the child's mouth to protect skin from draining oral secretions, keeping the pad free of wrinkles or creases. The child's head is turned to the side, and a pressure-relieving cushion is placed under the head and ear. The knees and feet are positioned off the bed with a roll placed under the distal femur and lower leg such that the toes are floating off the bed. Positioning devices should only have one layer of linen between the device or cushion and the child. The child is assessed to ensure that nothing is pressing against their skin and that their skin is not pinched in any way, that the spine is not excessively flexed or extended, that the nipples are not pinched, and that the penis and scrotum are unrestrained. The head of the bed should then be elevated 30 degrees in reverse Trendelenburg. While in the prone position, children should be repositioned every 2 hours. The turn requires at least 3 personnel to perform safely. Consideration should be given to the need for additional analgesia, sedation, and/or neuromuscular blockade to ensure the child's comfort and safety throughout the turn. To reposition the child while prone, one team member maintains the security of the ET tube while ensuring it does not kink. Ventilator tubing should remain lower than the child at all times. The child's chest is lifted off of the bed, while another team member turns the child's head to the alternate side. The child's head is returned to the bed with a pressure-relieving cushion under the head and ear. An absorbent pad is placed under the child's mouth, and the child's position is assessed to ensure that there is no excessive flexion or extension of the spine.